speak about the celiac disease. Is it underdiagnosed? Dr. Mohamed Almawardi is a consultant gastroenterology and transplant hepatologist in King Faisal Specialist Hospital and Research Center in Jeddah. Welcome, Dr. Mohamed. Can I start?
You have 20 minutes.
Sure. Thank you very much. Good afternoon, ladies and gentlemen. I was asked to talk about celiac disease, and I'm going to take you through a journey to give you some ideas about the celiac disease that obviously is being underdiagnosed, and probably we see some of cases that is being missed a bit when we do evaluation for a GI presentation or GI symptoms. So I'll be going through my outline of presentation through the epidemiology of celiac disease, and then following by the definition, pathogenesis of the disease, and then clinical manifestations, complications, treatment. And then I'll go over a couple of big studies that talk about the association between celiac disease and irritable bowel syndrome. Celiac disease has been described initially by Sir William Dyke. He's a Dutch pediatrician who documented an association between gluten diet, a gluten-containing diet, and small bowel enteropathy. This was almost in 1945. When we talk about the epidemiology, it was found in different studies that almost only 21% of the cases are being discovered, while the rest are being missed. In general, worldwide, the prevalence of the disease is around 0.6 to 1% of the population, and it's quite common in Europe, Middle East, and North Africa, more in female to male ratio 2 to 1. In the American Gastroenterology Association position statement, the prevalence of the disease in the US is almost 1 in 100, with reasonable range of 1 in 80 to 1 in 140, with an association in patients with first-degree positive history or positive family history of first-degree relative celiac disease. They have an increased risk of around 10 to 15%. What about in Saudi Arabia? Well, I actually tried to look over the PubMed search and the literature. There's not much in the literature, except a reported study, a cross-sectional study in pediatric cases in patients with type 1 diabetes. It was found that the celiac disease is almost present in 11% of those cases. We have to put in our mind an association with other autoimmune diseases, including type 1 diabetes, Hashimoto's thyroiditis, Down syndrome, Turner's, and IgA deficiency. So we always put in our mind when we do an evaluation for celiac disease patients. In genetics, this is quite important that we need to know about it. Why is that? Because HLA, DQ2, and DQ8, they have a very high negative predictive value. What does that mean? It means that if we do an evaluation and the serology is negative and the biopsy is still negative, that if the genetic testing is negative, that has a very high, that means definitely the patient does not have a celiac disease. So the definition, so as everybody knows, systemic immune-mediated disorder is triggered by dietary gluten in genetically susceptible persons. So that's a small diagram. It's a little bit busy, but I'm just going to give you a summary of that, of how does the celiac disease happen. So gluten-containing diet is composed of different forms of proteins, including prolamines, glutamine, and saccharins and hardenins. They're present in wheat, barley, and rye, okay? So when there is an exposure of the small bowel to any of those components, all right, in those patients, they have a deficiency in the ability to digest those kinds of gluten diet because of the deficiency of enteropeptidases. So what happens is, that by the presence of glutaminase with a gluten diet, it gets converted to, in the presence of tissue transglutaminase, it gets converted to a negatively charged protein or glutamine residue. This will accelerate a cascade inflammatory cell infiltrate in the presence of T helper cells, and that will result in the enteropathy and all the complication and malabsorption. So common presentation in those patients, including chronic diarrhea, which is the commonest cause of, or commonest presentation of those patients with celiac. Weight loss, abdominal distension, iron deficiency anemia. Again, iron deficiency anemia. So it's part of our clinical sense that everybody or whoever presents with evidence of iron deficiency anemia, I think it's reasonable to screen for celiac disease. Recurrent abdominal pain after stomatitis, short stature, high elevation in liver enzymes, and as an association in celiac hepatitis, chronic fatigue syndrome, and low BMD, bone mineral density. Dermatitis herpetiformis, and one of the commonest skin lesions, which is basically an IgA deposits in the mucosa of the skin, and epidermis of the skin, sorry, and that will result in a blistering form of presentation. Gluten ataxia and celiac crisis, which is common to see in pediatric age. Those patients in a minimum exposure to a gluten-containing diet, they can present with a catastrophic diarrhea and dehydration with renal failure. So genetic susceptibility and ingestion of gluten diet is necessarily to diagnose or to present celiac disease, but is not sufficient for the celiac disease to happen, or the loss of gluten tolerance and the development of celiac disease to happen. So how do we diagnose that? So I'm going to go over two forms of diagnosis. So serology, and screening of choice for serology is the anti-TTG IgA. It has a highest sensitivity, so when we look for the screening, we look for the highest sensitivity of the 95%. And we have to make sure that those patients, they don't have an IgA deficiency. So whenever you go and you order for TTG, you have to order for IgA class, subclass A, to make sure that those patients, they don't have a deficiency in IgA. And if there is a deficiency, you can order a anti-TTG IgG. How about anti-endometrial antibodies? It's good for high suspicion of the disease for patients with uncertain diagnosis because it has a high specificity. So it's the best use of it or utilization is the monitoring the response, not for initial diagnosis. For patients who recently, again, there has been a release of a new form of serologic test, which is a deammitated glycan peptide, and also it's useful in patients with IgA deficiency. Again, as I said before, HLA-DQ2 and DQ8 is having the highest negative predictive value. So for a patient with you still have a clinical suspicion, but the serology is negative, you may do this test if available, which is not available in all the centers. So serologic screening is recommended for all first-degree relative for patients with celiac disease. How about biopsy? So small bowel biopsy is the second form of diagnosis, and it's usually required to confirm the diagnosis. In one publication in pediatric AIDS, they stated that there's probably no need to go for the small bowel biopsy if the serologic markers and the HLA genotype is positive. As you can see, the endoscopic findings, classically, they present well with what they call a scalloping. There's severe villus atrophy of the mucosa lining, and usually it starts at the first and second part of the duodenum and goes worse as we go distally. So pathologically, there has been a release of the pathological classification of the severity of celiac disease that can range from an intraepithelial lymphocytes infiltrate to a crypt hypoplasia to villus atrophy, which is classified to subvillus, subtotal, partial, subtotal, and total villus atrophy. All right, so what's the treatment? The treatment is relatively simple, but logistically might be difficult. What does that mean? So consultation with a skilled dietitian. So we always have to have a good dietitian with us to instruct the patient how to avoid gluten-containing diet. This is extremely important. We have a problem in our culture that compliance is always an issue. I've been seeing lots of patients with trying to explain to them and instruct them that it's quite important to be strictly following the gluten-free diet, but it's always an issue. Education about the disease, lifelong adherence to the gluten-free diet, identification of the treatment nutritional deficiency, and access to the advocacy group, and continuous long-term follow-up by a multidisciplinary team. One of the problems that we face in gluten-free diet is the availability of the gluten-free diet. I always see patients and they're complaining, okay, I'm not able to access this. Where should I buy it? We got a couple of items here and there, but there's no an asserted centers for that. Advocacy group is not available also, so it might be something that we should think about it. So treatment again is a gluten-free diet. Our minimum gluten threshold is 10 to 15 milligram per day. So in a 25-gram slice of toast, there's a 1.6 gram of gluten. So you can imagine how low we should be strictly avoiding the gluten-containing diet. In a Codex Alimentarius regulation, they said a maximum contamination gluten should be at least a maximum of 20 ppm. All right, so how do we monitor for those patients? Follow-up is necessarily to confirm the diagnosis by an objective response to a gluten-free diet. No clear guidelines as the optimal means to monitor the adherence. And in general, monitoring adherence with serology is quite sensitive for major but not minor transient dietary indiscretion, usually after 6 months. How about biopsy? Do we really need to repeat the endoscopy and biopsy? I do recommend that, but it takes around 3 to 6 months after the normalization of the serologic markers to see the improvement endoscopically, or pathologically, I mean. So expected benefits, compliance is likely protective, so it's extremely important. We should emphasize the patients that they should be strictly following the gluten-free diet, because this has an impact on prevention of complications like Hodgkin lymphoma and dermatitis herpetiformis. Improvement in bone marrow density, improvement in nutrition parameters, the effect on diabetic control are inconclusive. Nutrition deficiencies should be considered: iron, folic acid, calcium, vitamin D, rarely vitamin B12. This is just some guidelines to that there is a need to do a bone marrow density densimetry as an initial assessment, and then accordingly after 1 year of the diagnosis you can repeat that, and accordingly you can take an action, whether you start the patient calcium vitamin D only or you jump into bisphosphonates. Certain different definitions has been specified for celiac disease. I don't need to go over that. The most important one is refractory. So what is refractory celiac? Refractory celiac is persistent with recurrent symptoms and sign of villous atrophy despite a strict gluten-free diet for almost a year. So there are 2 types of that, and we ask the pathologist to help us. So type 1 is with normal intraepithelial lymphocytes, and type 2, they have an abnormal intraepithelial lymphocytes, and they're associated with ulcerative jejunal ileitis and enteropathy-associated T-cell lymphoma, and that has an impact on the treatment. So always we have to think about our differential diagnosis of refractory celiac: malignancy, lymphoma, ulcerative jejunal ileitis, collagenous sprue, non-compliance or inadvertent ingestion should be always considered, lactose intolerance, IBD, irritable bowel syndrome, pancreatic insufficiency, bacterial overgrowth, and truly recovery. So complications, think about osteoporosis, impaired splenic function, neurological disorders, infertility, recurrent abortions, ulcerative jejunal ileitis, and enteropathy-associated T-cell lymphoma. So this is a new entity that has become recently released, which is non-celiac gluten sensitivity. So it's a variety of immunological and morphological or symptomatic manifestations that are precipitated by ingestion of gluten in people in whom celiac disease has been excluded. So if you compare, so there are 2 types of that: either gluten sensitivity or wheat allergy. Both of them are different from the celiac disease in the absence of serology and pathological evidence. So there is no evidence of antibodies and there is no evidence of enteropathy in both. Both of them, they can present with intestinal, extraintestinal symptoms, but they don't have a coexisting complications. And basically they're related to the immune response. All right, a couple of slides, a couple of studies that I want to take you over to show you some importance about the association of irritable bowel syndrome and celiac disease. The first one was a systemic review published in 2002 where they looked at the pretest, they wanted to determine the pretest probability of organic GI disease and the accuracy of diagnostic tests for organic GI disease in patients who meet symptom-based criteria for irritable bowel syndrome. So they looked at different basic blood works like CBC, lyse, urea, creatinine, TSH, fecal occult blood, and serology for celiac disease. And they went over a comprehensive literature review for studies examining this accuracy of diagnostic tests for organic GI diseases among patients who meet symptoms-based criteria for irritable bowel syndrome. The pretest probability for the prevalence of the disease in a pretest probability in those patients was quite low for colitis, colorectal cancer, and GI infection, thyroid, and thyroid dysfunction, but it was high in celiac disease. 22% of patients with suspected irritable bowel syndrome had positive antibody test. So 4.6% had positive histological evidence of celiac disease. So they came up with a conclusion that there is insufficient evidence to recommend the routine performance of standardized battery of diagnostic tests in patients who meet symptom-based criteria for irritable bowel syndrome. But based upon the increased pretest probability of celiac disease, routine performance serological tests for celiac disease may be useful in this population. So always think about celiac disease as in patients presenting with irritable bowel syndrome. Another study showing the yield of diagnostic tests for celiac disease in patients with symptoms suggestive of irritable bowel syndrome. It was a systemic review, a meta-analysis conducted to estimate the prevalence of celiac disease in unselected adults who met diagnostic criteria of irritable bowel syndrome. Sorry, it's a little bit busy. So 14 studies were identified, 4,000 patients were involved, almost 2,200 of them met diagnostic criteria for irritable bowel syndrome. The pool prevalence for positive IgA and positive endomysium antibody or anti-TTG and biopsy-proof celiac was 4%, 1.6%, and 4% respectively. And the odds ratio was high in all of that, including 3, 2, and 4. So the conclusion was the prevalence of biopsy-proof celiac disease in cases meeting diagnostic criteria for irritable bowel syndrome was more than 4-fold that controlled without irritable bowel syndrome. So not only the symptoms of irritable bowel syndrome and celiac disease overlap, but also they can have an association, 4 to 5 times fold increase in the risk, especially in patients seeking health care. Conclusion, celiac disease should be considered always in our assessment of irritable bowel syndrome. Treatment of celiac disease requires a full counseling with the help of a dietitian, and attention should be given to patients presenting with refractory celiac disease. Thank you.